Good day. My name is Dr. Denise Chan. I'm one of the radiologists at Foothills Medical Center in the Department of Nuclear Medicine here in Calgary. I want to thank the AGAT Foundation for this opportunity to talk about PSMA PET and Alberta. The first thing I want to do is to discuss a case of a patient, a 69-year-old male who had a PSA of 95.2. There was a clinical suspicion for prostate cancer. He had a staging CT and bone scan here in Calgary, which were negative for metastasis. An MRI of the prostate was performed, and it showed a tumor in the posterior right prostate gland. Now, there was heterogeneity in the left prostate gland, but the radiologist could not definitely find a tumor in this region. The prostate MRI also called the seminal vesicles normal and no lymph node metastasis. However, given the elevated PSA, the radiation oncologist was concerned about metastatic spread, and this would be important for therapy, as it was a difference between systemic therapy versus radiation therapy. The PSMA PET-CT was performed, and indeed it showed prostate cancer in both the left and right aspect of the prostate gland. Additionally, there was abnormal uptake in the seminal vesicles, consistent with local extent of disease. And there was abnormal lymph nodes in the bilateral pelvis. So this identified disease that was not seen on CT or MRI. Unfortunately, the patient had to actually travel to Montreal to have this PSMA PET-CT, as this is not available in Alberta at this time. The patient had to pay his own PSMA PET-CT as well as lodging and airfare to have this imaging modality, which changed the management of his disease. So today I'm going to talk about PSMA PET-CT and its role in the evaluation for prostate cancer. There has been an increased focus on PSMA as a target in imaging and therapy since its introduction in 2013. And since then, it has played an important role in the diagnosis, staging, and restaging, as well as guiding appropriate therapy in the setting of biochemical recurrence and staging. Since its inception in Australia, it has now become routine clinical use. However, it is not Health Canada approved here in Canada, so it's only for research today. So we will discuss PSMA PET and its potential indications on this presentation. So what is PSMA? PSMA is a glycoprotein on the cell membrane, and it's expressed in prostate cancer. Most prostate cancer cells express PSMA, and its expression increases with advanced disease, increase in Gleason score, increased PSA, as well as castrate-resistant metastatic disease. So the idea is to take a PSMA ligand, a protein that binds to the PSMA on the cancer cells, and to attach it to a radioactive substance, such as fluorine-18 or gallium-68. Now, these are positron emitters, and this can be used to identify disease on a PET-CT scanner. So the PET-CT technique is inject the patient with the radiotracer, and there are several that we could use, such as F18 PSMA 1007 or gallium-68 PSMA 11. Patient gets injected, waits 60 minutes, and then they undergo their PET-CT or PET-MRI, depending on what center you're in. This is an example of the normal distribution of a PSMA PET. As you can see, there's uptake normally in the lacrimal glands, salivary glands, liver, spleen, kidneys, bowel, and bladder. That's normal distribution. So what are the potential indications for PSMA PET? Research has shown that there are two main indications that PSMA PET plays a key role in. The first is primary staging in patients with high-risk disease, and the second is biochemical recurrence in patients with low PSA values. Other potential indications include patients with negative biopsy but high clinical suspicion for prostate cancer, monitoring response to systemic therapy, active surveillance, as well as evaluation for lutetium-177 PSMA therapy. So first, let's talk about the PSMA PET in the detection of intraprostatic tumor. Now, normally, you would identify the tumor with either ultrasound or MRI, and then have a biopsy. Routine use of PSMA PET prior to biopsy is probably not needed unless there's a contraindication to biopsy. And even then, it would probably be reserved for high-risk patients who have a Gleason score of 7 or elevated PSA greater than 10. It's unlikely to benefit patients with lower-grade prostate cancer. In terms of the research actually shows, though, that if you can't identify disease on MRI, you have a better chance of identifying it on PET and MRI. So taking the PET and MRI combined together using both imaging modalities, you can have a sensitivity in detecting disease of 67%, whereas looking at the MRI alone, the sensitivity is 42%. Now, when I say PET MRI, it could actually be just taking a separate PET and an MRI and reviewing the two together, or it could actually be a PET MRI hybrid machine, which is available actually in Edmonton. But overall, having the PET improves the sensitivity in detecting disease compared to MRI alone. In terms of PSMA PET in primary staging, we know that the accurate pretreatment staging of disease outside of the prostate gland is very important, particularly identifying lymph nodes. This is especially important for patients who are high risk and probably also benefits patients that are intermediate risk. The reason being is that conventional imaging such as CT and MRI sometimes is not able to identify metastatic disease. The gold standard is actually surgery with a pelvic lymph node dissection. It's the most accurate way for assessing the lymph nodes. However, there are side effects to having surgery, such as increased lymphocytes and clots in the legs. In one study looking at 130 patients with intermediate and high-risk prostate cancer, comparing conventional imaging to PSMA PET, they found the sensitivity is 66% for PSMA PET compared to 44% for CT and MRI. And the reason being is that PET PSMA is able to identify disease in lymph nodes that are smaller than what is detected on CT or MRI. CT and MRI is able to identify lymph nodes that are 1 centimeter or greater, or if they lose the normal shape of the lymph node. However, PSMA PET is able to detect disease in lymph nodes as small as 5 millimeters. So that's probably why it has an improved detection rate. And it's also useful for bone metastasis. Currently, when there is clinical suspicion for bone metastasis, we do a bone scan. Bone scans are excellent. However, PET PSMA seems to perform better with a 96.2% sensitivity compared to 73% on a bone scan. Also, bone scans are dependent on the PSA. The higher the PSA, the improved sensitivity. Whereas with PET-CT lower PSAs, you can still detect disease. And metastasis can be identified in other organs, such as the lung and the brain, as well as the liver. The second main indication for PSMA PET is in the setting of biochemical recurrence. This is when there's an increase in PSA following radical prostatectomy or post-radiation. Biochemical recurrence after radical prostatectomy occurs in up to 50% of patients, and the detection of recurrence is important as it guides optimal treatment. You can avoid futile localized treatment if the metastatic lymph nodes are outside of the radiation field of view, and you can avoid systemic treatment, which has potential side effects, if you can localize the disease and treat it with radiation therapy. So the most significant reason for failure of salvage therapy is not being able to detect metastatic disease. So in a meta-analysis looking at PSMA PET with biochemical recurrence, they found that the PSA as low as 0.2 is able to detect disease in 48%, and it increases with increasing PSA levels. Another study looking at the accuracy of gallium-68 PSMA in recurrent prostate cancer found that they were able to detect disease as low as 0.5 PSA levels, and the detection rate was 38%. And with PSA levels greater than 5, the detection rate was 97%. So how does this compare to conventional imaging? Conventional imaging at this time has low diagnostic yield. A bone scan detection rate is 5% when the PSA is less than 7. For CT, the sensitivity is 11 to 14% in identifying local recurrence and lymph node metastasis. So the conventional imaging is not performing as well. Whereas when you compare it to PSMA PET-CT, the detection rate is 76%, depending on the PSA level. Now, this is important because patient prognosis significantly improves when you're able to start salvage therapy greater than when the PSA level starts to increase at 0.5. And right now, currently, PSMA PET has a detection rate superior than any other imaging modality currently available. In terms of one study, in patients with increased PSA after radical prostatectomy, these patients were potential candidates for salvage therapy. When they underwent PSMA PET, this changed management in 29% of the patients, as they were able to identify metastasis outside the proposed radiation field. So this was able to change management in ways that conventional imaging is not able to. So how does PSMA PET compare to other PET tracers that you have heard about in literature in the last few years, such as F18 choline? Right now, the PSMA PET tracer performs better than other previously studied PET tracers, such as F18 choline. For example, detection rate for biochemical recurrence, the detection rate with PSMA PET was 66% compared to choline, which was only 32%. In terms of PSMA PET treatment response, at this time, more studies are needed to evaluate whether or not PSMA PET has a role following chemotherapy, as there sometimes has been a flare response described following androgen deprivation, in which case it can look like disease is progressing on PSMA PET, but actually it's a healing response. So more studies are needed to evaluate whether it's going to be useful in this role. Now, what about PSMA as a target for radionuclide therapy? So I mentioned before that you can image the patient on a PET scanner using F18, fluorine-18, or gallium-68. You can actually replace those radioisotopes with a lutetium-177. Now, lutetium-177 is a beta emitter. This beta particle can cause damage to the DNA of tumor cells and cause cell death. So there has been studies now looking at lutetium-177 as a target for radionuclide therapy for prostate cancers, and the studies have so far been quite promising. The role of gallium or PSMA PET-CT is to help map out the therapy, where the metastatic disease, and whether or not the patient would benefit from the lutetium PSMA. So here we have an example of a patient who had a PSMA PET, and you can see all the metastatic sites of disease, and a baseline lutetium PSMA PET. And over subsequent therapies, you can see the metastatic disease improves with time. So where are we in terms of the status in Alberta? So currently in Canada, PSMA PET is not Health Canada approved. It's only allowed for research through a clinical trial application. So it's only for research, and it's not currently funded by Alberta Health Services for routine clinical use. Now, there are other centers in Canada, such as Montreal, Toronto, and Vancouver, who are able to do PSMA PET-CT through their research funding. Currently, in the Edmonton cyclotron group, Dr. Frank Wiest and his team is currently working on producing an F18 PSMA 1007, which will hopefully be available in the next year, and which would be available to both Calgary and Edmonton. So Calgary has 2 PET-CT scanners. We do not yet have our own cyclotron, so we will be dependent on Edmonton for delivery of this radio tracer, and we would share it with Edmonton hospitals. There are at least two studies that we are going to be working on here in Calgary, with Dr. Stephen Yip going to describe both research trials. One is a multi-center trial working with prostate cancer, and the second is a local Calgary trial, which he will discuss next. Thank you.
Thank you very much to Dr. Denise Chan for her talk. I'm Dr. Steve Yip. I'm a medical oncologist at the Tom Baker Cancer Center, and I'm pleased to present to you on promoting personalized prostate cancer care and beyond. And I'd like to thank the AGAT Foundation for this opportunity to present this presentation. These are my disclosures. Here I'd like to outline how we'll approach this talk. First, examining the complex landscape of advanced prostate cancer, then specifically delving into current academic achievements and where we're focused now in prostate-specific membrane antigen, as well as genomic or DNA-level biomarkers to enhance personalized cancer care. We'll focus on how these are targets for novel therapeutics, and our vision for the future study and implementation of these critical resources here in Alberta. First, I'd like to give you an outline of the epidemiology of prostate cancer. We understand that it affects many gentlemen throughout their life. It is the commonest cancer that affects men, and we see that it is the third leading cause of cancer-related death in Canada. We see that there are about 21,000 new cases in Canada, and we see that about 1 in 7 gentlemen will be diagnosed with prostate cancer. 1 in 29 will die from their prostate cancer, and thus it is necessary to enhance how we approach this therapy, as we know that we can undertreat some patients and sometimes overtreat patients, and we need more elegant tools to examine how we can improve the care of our patients here in Alberta. So here we're focused on clinical presentation. A lot of patients are typically presenting with just screening, where they might have a PSA done by their physician, their family physician, who may just be doing this at screening, and it might be elevated. Sometimes they might develop local symptoms, such as troubles with passing urine. And sometimes when it is very advanced, we can see that they can develop bone pain, and sometimes they can develop swelling. This is an overview of how we might manage prostate cancer. And in the top left, this is early local disease that does not have any metastases, meaning any spread outside of the prostate. This is defined typically, conventionally, by imaging by a CAT scan or a CT scan or a bone scan. We can also find that patients develop metastatic disease, which spreads outside of the prostate and the pelvis. And this is typically treated with androgen deprivation therapy. This drives down the testosterone, which is a major driver of prostate cancer. This androgen deprivation therapy can inevitably fail in the advanced prostate cancer space. And even when patients don't have any disease that has spread metastatically, we can find that they can develop castration-resistant or hormone-resistant disease despite being put on androgen deprivation therapy. In this space, we know that androgen deprivation therapy is the backbone of how we treat these patients, but we've found that earlier initiation of therapies in this space can improve patients' outcomes. This is specifically looking at patients who are treated with metastatic castration-resistant prostate cancer, typically found to have about a 2.5 to 3 year median overall survival when they have metastatic hormone-resistant prostate cancer. Initially, we typically treat them with novel androgen receptor targeted therapies that overcome this resistance with agents such as abiraterone or enzalutamide. Inevitably, they go on to progress, and we have to consider chemotherapy such as docetaxel. At that progression, we can then consider other chemotherapies, other androgen receptor targeted therapies, but we certainly need to think of other academic initiatives and more promising therapies that might be more tolerable. And this is why we can expand upon this in utilizing new resources that exploit understanding the DNA makeup of this disease, as well as understanding that a lot of patients who have prostate cancer can overexpress this protein called prostate-specific membrane antigen, or PSMA. And by doing genomic testing through a technique called next-generation sequencing, and by performing prostate-specific membrane antigen PSMA PET imaging, we can understand the patient's disease much more clearly and bring the way we treat patients today into the new future of how we can treat patients in the near tomorrow. Prostate-specific membrane antigen, as highlighted by my colleague Dr. Chan, is overexpressed as a transmembranous protein, meaning that it is a protein that is seen on the cancer cells of prostate cancer. And we can target this, especially when we see that it is overexpressed in about 90% of gentlemen who have advanced disease. This allows us to identify it through imaging with PSMA PET imaging. It allows us to identify the disease. We can stage it and understand the extent of the disease, and potentially we can harness this as a therapeutic target of treatment. This is allowing us to identify patients who have disease that recurs after their early local therapy much more early on. And it allows us to understand how best to treat these patients in the more advanced spaces particularly. Yet this is not yet standard of care. So even though we might be seeing very promising results where prostate-specific antigen, or PSA, is being identified to detect metastatic disease that has gone elsewhere very earlier on, we need to identify how we can gain access to this resource in Alberta. As it is not standard of care, we are gaining great lengths of how we can bring prostate-specific membrane antigen PET-CT into our province through research initiatives, the most appropriate use of this technology so that we can get this to our patients earlier on. PATRON is a clinical trial that is a multi-center phase 3 clinical trial that we have participated in the development of, that is now supported by the Prostate Cancer Initiative, where we have gained the Translational Acceleration Grant. And this looks specifically at patients who have high-risk local disease or biochemically recurrent disease. And typically, we would stage these patients with a typical standard of care CT or bone scan. But this trial looks at patients being randomized to receive a PSMA PET image or a standard of care CT and bone scan image. And depending on the PSMA PET imaging result of those patients who receive the PSMA PET, they have treatment intensification around what is found on this imaging. And the final objective is to examine their time to develop failure or death in their treatment plan. We are also looking at how we can integrate this technology into clinical care locally, and we need to understand how we can use this as a therapeutic target. So lutetium and actinium, as well as thorium and other novel agents such as BITE, are harnessing the prostate-specific membrane antigen as a target for a systemic therapy of how we can treat advanced metastatic prostate cancer. By harnessing these sites of disease, we can then target this with radioligand therapy, emitting radiation specific to the site of the disease. We've found that there's early evidence of a potential benefit of lutetium-177 PSMA in the advanced, well-treated metastatic castration-resistant prostate cancer space, where we see excellent response rates in patients who have received many of these lines of therapy that I outlined previously. Pluto is one such trial that we have developed as a national multi-center clinical trial that looks at patients who have metastatic castration-resistant prostate cancer. In order for us to identify those patients who would be appropriately treated with a lutetium PSMA, they must have PSMA-positive PET scans. So we need to gain access to the PSMA PET imaging to identify those patients who could potentially be enrolled. Patients will be randomized to receive lutetium PSMA or standard of care docetaxel chemotherapy after they have previously received abiraterone or enzalutamide in the metastatic castration-resistant prostate cancer space. At progression, patients will be allowed to crossover, meaning if you were randomized to receive docetaxel chemotherapy, you will then be allowed to go on to receive lutetium PSMA, which is attractive to those patients who might not necessarily receive the study drug. The primary endpoint is radiographic progression-free survival. We will be looking at a variety of other objectives, including overall survival and quality of life. And this has also been supported by Prostate Cancer Canada Translational Acceleration Grant in November. Though this is promising, we understand that PSMA PET imaging and PSMA-directed therapies are still experimental and not yet standard of care. They are some of the most promising areas of how we can treat these patients in the near future, but we don't necessarily know how this impacts clinical management, which is why we need to look at this in the clinical trial setting and bring this earlier on to our patient population. To our knowledge, we have not yet established how patients' clinical management is impacted by PSMA PET in the advanced prostate cancer space. And there is thus an unmet need to gain access to this imaging. So we propose a clinical trial here locally to be able to gain access to this invaluable resource and to examine its impact on subsequent management of advanced prostate cancer. So the PSMAN trial is one that we have developed here, looking at patients who have biochemical failure or metastatic castration-sensitive prostate cancer, or castration-resistant prostate cancer, either metastatic or non-metastatic. We look at the impact of PSMA PET imaging on the management of advanced prostate cancer, comparing a pre-PSMA PET questionnaire to a post-PSMA questionnaire after they have had PSMA PET imaging. We're aiming to at least recruit 66 patients with the primary objective of the rate of alteration of clinical management of any therapies or biopsies or other changes that we might see impacted in typical standard of care imaging. The nuclear medicine cost is outlined here at about $2,000 if the sample is about 70 patients. In total, we'd be looking at about $136,000 per patient. But then there are additional costs with staff resources analysis, bringing this into prime time, and we'd be looking at just under $190,000. If we were to expand this to gain access to it to a much broader patient population for 140 patients, we would be looking at about $359,000 budget that we would be hopefully obtaining in the near future. PSMAN is very promising as we think that it will impact our clinical care and our understanding of why we need to bring this into standard of care and argue to the taxpayers why this should be offered to general patients in our general patient population in Alberta. We will determine the impact of clinical management in advanced prostate cancer space. We will get immediate access to patients as soon as we're able to activate this trial. We will gain access for future clinical trials, and we will have the potential impact on patient outcomes. Shifting gears here, I'd like to now shift into DNA damage repair mutations. We understand that the DNA microscopic level of prostate cancer, that we can see that individual genes and DNA can be affected in patients who have advanced prostate cancer, affecting 15 to 30% of patients with metastatic castration-resistant prostate cancer. And this can be inherited from family line down, affecting about 6 to 12% of patients. But in general, we can see this affecting the tumor tissue level that could just spontaneously develop at the cancer level of the tumor of about 23 to 30% of patients. This has potential prognostic, therapeutic, as well as familial screening implications. In identifying this, we could potentially offer testing to patients who could be at risk of developing subsequent cancers if their relative is found to have one of these DNA changes. The commonest DNA change or mutation might be found at the BRCA gene, BRCA1 or 2, and ATM is another gene that can be affected, as well as a variety of others. We understand that BRCA and ATM, these DNA damage repair genes, are necessary for DNA repair. As well, PARP is another method in which DNA appropriately repairs, and we see that at the cancer level, we can see that these DNA repair mechanisms can be affected in about 15 to 30% of gentlemen. So therefore, if we target the other mechanism, PARP, by introducing a PARP inhibitor, such as olaparib or niraparib or talazoparib, and so on, we can potentially exploit this DNA break and induce death of cancer cells. And this has hit prime time now with the New England Journal of Medicine publication looking at PROfound, the olaparib versus physician's choice AR targeted therapy or androgen receptor targeted therapy trial. There was a phase 3 clinical trial that looked at gentlemen who had previously been treated with abiraterone or enzalutamide with metastatic castration-resistant prostate cancer. They had 2 different cohorts looking at patients who had BRCA or ATM gene mutations, and cohort B, other DNA damage repair mutations. In each individual cohort, patients were randomized to receive olaparib, the PARP inhibitor, or physician's choice androgen receptor targeted therapy, with the primary endpoint being radiographic progression-free survival, so the time to developing progression of their disease or death, as well as overall survival in the cohort A, the BRCA and ATM gene mutated patients. The primary endpoint that was most important for us to all see was reported at the ESMO Congress that looked at patients who have BRCA or ATM mutations. And this is a Kaplan-Meier curve which basically shows the median survival rates of patients who are randomized to receive olaparib or physician's choice AR targeted therapy. So here you see in the maroon line those patients who had olaparib, And you have in the blue line those patients who had received the physician's choice therapy. And what this depicts is that the survival rates are significantly improved in those patients who had olaparib, with these two curves separating in favor of those patients who had olaparib at about 19 months of median overall survival, compared to physician's choice about under 15 months of overall survival. This was also taken into account looking at individual genes that could be affected. And largely what we see is BRCA or BRCA2 patients are finding the most benefit. But there's a lot of genes here that are in low samples, so we need to understand them more clearly before we really understand how best to treat them. Nevertheless, this is very promising data, but basically what this plot shows is those patients who fall to the left of the line that is dotted at a hazard ratio of 1 are having favorable survival rates when they're treated with olaparib. So what you'll see is the BRCA2 or BRCA2 patients really having that great benefit, but I would not write off these individual patients with these small gene mutation samples. So we need to understand this before we really jump to conclusions and say, well, this is only for BRCA2. This has led to Health Canada approval for olaparib being approved for the therapy of patients who have BRCA1 or 2 or ATM mutations in metastatic castration-resistant prostate cancer after treatment with androgen receptor targeted therapy, which underlines the necessity of identifying these genes, yet we don't have any access to genomic testing to identify those patients who would be appropriate candidates for this therapy. Right now, we are participating with a variety of clinical trials upcoming in the near future, as well as currently, TALAPRO-2, the GORC cohort study, the Capitello study, and ARC-6 are all in the midst of helping patients gain access to therapies and clinical trials that are guided by genomic testing. But we understand that this is very important, but not yet a standard of care in Canada, despite national NCCN guidelines, largely based around American or European guidelines, to suggest that this should be offered in patients who have metastatic disease for genetic testing regardless of individual criterion. But it is necessary to think about the costs to the taxpayers and how we can feasibly identify these DNA mutations. When patients go on to develop castration-resistant disease, oftentimes we'll see disease that spreads to the bones. And we'll see that the DNA level changes can occur later on throughout the evolution of their disease. So their early disease might not necessarily reflect their later disease, thus underlying the need to really characterize this genetic level of data more clearly, both by liquid biopsies gathered by a blood and a tissue biopsy sample. So we can sample a patient's blood, spin it down, separate it, look at the plasma, which has circulating DNA. Within that circulating DNA, we can find circulating tumor DNA that's being shed by the cancer cells. And by performing next-generation sequencing to look at the individual genetic changes, we can understand the genetic makeup of the prostate cancer. We can also understand this from biopsies of the tumor tissue, but this can sometimes be technically not feasible because we're trying to biopsy a bone, which can be very challenging, it can be of low yield, and sometimes quite painful and difficult for patients to undergo. Our objective to introduce the personalized medicine in prostate cancer, APCARI, Alberta Prostate Cancer Research Initiative 03, a real-world study to Alberta, is to collect information with patients who have metastatic castration-resistant prostate cancer to identify those individuals who have DNA damage repair mutations, not only within Alberta, but Western Canada, as a collaborative initiative unifying the nation potentially in the future. Our aim is to streamline access to germline and somatic DNA damage repair genetic testing, to validate a next-generation sequencing platform through Alberta Precision Laboratories so that we can, in the future, bring this to standard of care to offer this testing to our individual patients in real world. We will be gaining access to this for 200 patients, and we will be examining this variety of genes these DNA damage repair mutations, these other prostate cancer relevant genes, as well as these other cancer-related relevant genes. The impact could be quite broad. We gain access to the essential testing in Alberta, thus guiding treatments, thus affecting patients' understanding of their prognosis, potentially impacting their family members, and improving patient outcomes by gaining a tailored approach that is precision medicine focused on the individual patient, allowing access to new therapies such as PARP inhibitors or platinum-based chemotherapies. This is conditionally approved through AstraZeneca Merck grant, and we really do need to expand upon this beyond the 200 patients. Our hope is to deliver this to the entire province and eventually unify all of Canada so that we can offer this resource to many patients who could have their care benefited. This is our budget right now with ABCARIO 3. We are aiming to potentially offer this in the future to 640 patients in the first year, 700 patients in year 2 to 4, so that we can really establish this genetic testing, validate it, ensure that we can make a strong argument to the general group of patient population and the taxpayers as to why this should be offered so that we can affect their care. So our vision for the future of metastatic castration-resistant prostate cancer management is to offer genetic testing earlier on, to understand how this could impact patients' future therapies with PARP inhibitors such as platinum-based chemotherapies, to be able to offer PSMA PET-guided imaging so that we can understand how to target this with new radioligand therapies, as well introduce this earlier on in the disease course to understand when we should be intensifying earlier disease and when we should perhaps pull back from more aggressive disease. With that, I'll thank all of our collaborators, all of our patients who have participated, Dr. Denise Chan, and I would answer your questions, but this is virtual. Thank you.